Our next presentation will stay in Asia and will pick up on some of the issues that Kakan mentioned. And Dr. Uday Ghoshal is a professor in the Department of Gastroenterology in Lucknow, where he is in charge of gastrointestinal pathophysiology and motility. He is also a founder member of and Secretary General of the Asian Neurogastroenterology and Motility Association, as well as the National Coordinator of the Indian Society of Gastroenterology Task Force on Irritable Bowel Syndrome, and has also contributed to the Asian consensus on irritable bowel syndrome. Uday.
Thank you. I first thank Rome Foundation and World Gastroenterology Organization for this initiative. I come from India. This is my institute, and I bring greetings from the institute to you. What is culture? This has been amply highlighted. Culture is the value, belief, and practice of a particular group that are learned and shared, which guide thinking, decision, and action in a particular way. So what we do in the adult life, partly we have learned in the childhood. And because the training is so different in the different parts of the world, this will actually lead to difference in the health interpretation of the symptom, health outcome, and satisfaction to the health care. And language is the vehicle by which culture is expressed. If I show you the next slide, you will realize that when we talk about language, in any country you have one language. But if you look at India, officially there are 18 languages. Obviously, what will happen is that for validation of questionnaire for India, multilinguistic nature of the country needs to be considered. And we not only talk about country-to-country variation, but intra-country variation when we are talking of a disorder like IBS, which is so subjective in nature. This has already been said, that we know that if you look at any study, frequency of IBS is somewhat lower in most Asian countries than West. We had a study in which we found 4.2% was the prevalence, but obviously in that study we did not use Rome criteria. But recently there is another study in which the same data, that is 4%, was reproduced using Rome 3 criteria. What does it mean? That prevalence of IBS is lower in Asian countries, the reason for which we don't know. Now, this is one of our study which we did. This was a multi-centric study involving 18 centers all over the country. And in this, we recruited 2,785 patients of IBS. Now, if you look at the symptom profile of this patient, interestingly, abdominal pain and discomfort was present in 70%, 30% it was absent. The pain and discomfort is the essential for Rome criteria for the diagnosis of IBS. Another interesting issue there is abdominal pain was present only in 50%. That means almost half of the patient did not report pain. So therefore, pain is not a marked feature in India. And this is one study which is a multi-country study or multinational study where you see that pain score was lower or lowest in Indian patient. So pain is not a marked feature. Another issue here is when we asked this patient whether they felt constipated or whether they felt having diarrhea, 53% said they felt constipated, 47% felt they had diarrhea. But when we applied the stool frequency criteria, you see of 1,404 patients who said they are constipated, only 507 could be classified by frequency criteria as constipation. Of 1,252 who felt having diarrhea, actually only 50 could be classified as diarrhea based on the frequency criteria. So when a physician is sitting in the OPD, he has to look at the feeling of the patient and give treatment, either laxative or constipating drug, depending upon the subjective feeling of the patient rather than criteria driven, which is many a time made by us. And why does it happen? So what happens is if you apply the frequency criteria, a large majority of the Indian patient remain unclassified, neither constipation nor diarrhea. Why does it happen? If you look at simply this chart, which came out from the same study where we had 4,500 healthy community subjects, and we asked them a simple question that, do you feel constipated? What is your stool frequency per day? This is the thing we asked, that what is your stool frequency per day? Interestingly, 56% passed 1 stool a day and 34% passed 2 stools a day. So normally Indian population, they pass at least 1 to 2 stools a day. This is the reason that why we could not classify, because this may be related to the high fiber diet and rapid gut transit time. Here I charted all the data for our whole gut transit time. North India 39 hours, South Africa 33 hours, Uganda 35 hours. Look at the two studies in UK, 83 hours and 76 hours. So there is a short gut transit time in this population. So what happens is Indian mother teach their children to defecate 1 to 2 times a day and to take fiber-rich diet. Vegetarianism is very common in India, and vegetarianism is associated with the high fiber intake. 90% Indian healthy people pass 1 to 2 stool a day, I said that. And whether the patient felt constipated or diarrhea, their stool frequency was same. What they talk about is feeling of incomplete evacuation, which was the major symptom. And another issue is recent trend of increasing consumption of low fiber westernized diet might result in less stool frequency, and therefore, though they are passing 1 stool a day or 5 stool a week, they will report as constipation. This is another issue, lactose malabsorption. Lactose malabsorption is very common in Indian adult, and this is one of our study where we found 82% IBS had lactose malabsorption, 77% control had lactose malabsorption. Therefore, there was no difference. But look at the bottom pie chart. It shows that patient with IBS with lactose intolerance, when they were given lactose load, they were more symptomatic than the control subject. What does it mean? The same volume of gas resulting from fermentation of lactose, IBS people cannot tolerate, control can tolerate. This is because of visceral hypersensitivity, and obviously there, if you stop lactose, he will symptomatically benefit. Not only that, in India, we did a study where we studied northern India and southern India, and we found difference in the frequency of lactose malabsorption. And this is related to the genetic difference, because the northern Indian population is genetically having more of Aryan genes. On the other hand, southern Indian population is having more Dravidian genes. And in fact, recently there is a paper in Nature on the genetic composition of Indian population. This is another issue I like to highlight. Bacterial overgrowth. Pimentel found that 78 to 84% patient of IBS had bacterial overgrowth. But when we studied, only 10% had bacterial overgrowth in India, at least 3 studies. Because there is a difference in the methodology. Glucose hydrogen breath test was used by us. This is very specific, though not so sensitive. Pimentel used lactulose hydrogen breath test, and he presumed that mouth to cecum transit time is always more than 90 minutes. Therefore, before 90 minutes, if you get a peak, this is the bacterial overgrowth. Look at the data. Median orocecal transit time among Indian adult is 65 minutes. Median orocecal transit time in Taiwan is 85 minutes. What does it mean? All this healthy population who had a fast gut transit, if you use lactulose hydrogen breath test and use this criteria, they will be bacterial overgrowth positive. So therefore, I will suspect a lot of these are false positive. Now, another issue I want to highlight. For decades, Indian physician noted that an IBS, when he doesn't respond, give him metronidazole, he responds. But this was never documented. In our study, we documented that of 2,785 patients, 1,237 received metronidazole by the community physician, and almost half of them responded. Now, possibly there is a link there. We thought initially, is it possible that IBS is caused by Entamoeba histolytica? In fact, WHO had a classification called non-dysenteric amoebic colitis. This is a community study where we found frequency of Entamoeba histolytica cyst-passer state was equal in control and IBS. And when we cultured this amoeba, actually these were mostly non-pathogenic amoeba by gymodem analysis using SDS page. This is the follow-up data of those patients, and we found those spontaneously, in a lot of them, the amoeba cyst got eradicated but they did not have disappearance of their IBS symptom. Therefore, I think this non-dysenteric amoebic colitis is a misnomer. This is IBS with asymptomatic, non-pathogenic amoebic cyst pusher state. Now, this is another study from India in the same year, published in Lancet. They found a similar result. So, there is no relation between amoeba and IBS, but then why did this patient respond to metronidazole? This is possibly because of bacterial overgrowth, which we are realizing today. Now, another issue I'll bring and then end my talk. This is issue on post-infectious IBS, which is being talked everywhere in the world today. But what I believe is, if somebody develops acute infective enteritis, he will have two types of outcome. Either he will have complete recovery or he will have continuing bowel disturbance. Continuing bowel disturbance may be post-infective IBS or post-infective malabsorption syndrome, popularly known as tropical sprue. Now, this is the study from India done in 1960, where they found after an attack of acute gastroenteritis, 10% of the population continued to have liquidity and high frequency of stool for next 1 or 2 years. Now, if you look at this, does it not fit into post-infective IBS, which we are talking today? It does. But what does it mean? That unless we do test for mucosal malabsorption, we should not say post-infective IBS, we should say continuing bowel disturbance, which may be malabsorption or IBS. Therefore, I say post-infective IBS is usually diarrhea predominant. Tropical sprue has diarrhea. Tropical sprue is often associated with small intestinal bacterial overgrowth. We are realizing the same with IBS, particularly diarrheal type. In studies on PI IBS till date, no test for mucosal malabsorption has been done. 10 to 20% patient after acute gastroenteritis develop IBS. Same is the frequency reported for tropical sprue. And small intestinal permeability abnormality, which is like test for mucosal malabsorption, has been reported to be abnormal in tropical sprue as well as post-infective IBS. So there is an overlap. Thank you so much.